In this section, we will be learning about communication disorders. The disorders of communication include deficits in language, speech, and communication. Now, talking about speech, it is the expressive production of sounds, which includes an individual's articulation as to how efficient is the individual to utter words. Fluency is how easy were these words communicated, and how was the person able to sustain discourse or exchange of messages. Now, the voice pertains to the expression of the person through words, and resonance may actually be pertaining to the sound or the quality of the sound that could be described as reverberating, full, or deep. Now, moving on to language. The language is about the form, the function, and the use of a conventional system of symbols, meaning how efficient is an individual to communicate through spoken words, sign language, written words, pictures, especially in a rule-governed manner for communication. Now, communication is the third aspect that is to be observed in the communication disorders. Communication pertains to any verbal or nonverbal behavior, whether intentional or unintentional, which likely influences behavior, ideas, or attitudes, or it could be the influence it could also get across another individual. In assessing individuals who may actually have communication disorders, it is not easy to also establish, since we need to also secure that assessments of speech, language, and communication abilities must take into account with the individual's cultural and language context, particularly for individuals growing up in bilingual environments. The standardized measures of language development and of nonverbal intellectual capacity must be relevant for the cultural and linguistic groups, meaning the tests developed and standardized for one group may not provide appropriate norms for a different group. So if you are to check and test communication disorders or deficits of individuals relating to communication disorders, utilizing a tool from the American normed standardized test and be giving it to Filipinos, then it might actually be a different story, since we need to also look into the appropriate norms for the Filipino people, since we are considered to be multilingual individuals. Now, first on the list for communication disorders is the language disorder. These are the difficulties in the acquisition and the use of language due to the deficits in the comprehension or production of vocabulary, sentence structure, or discourse. Now, this statement is also our principal symptom. And pertaining to this principal symptom, usually we would also notice that the deficits likely affect the person's vocabulary and grammar, meaning the first words and phrases are delayed whenever the person is communicating or giving speeches. Vocabulary size is smaller and less varied, meaning the person is just utilizing simple words, and likely sentences are shorter and less complex. Which brings us to the idea that the core diagnostic features of language disorder are difficulties in the acquisition and use of language due to the deficits in comprehension or production of vocabulary, sentence, structure, and discourse. The language deficits are evident in spoken communication, written communication or sign language, and language learning and use is independent on both receptive and expressive skills. When we speak of the expressive ability, it refers to production of vocal, gestural, or verbal signals, meaning they are coming from the individual and how they are basically produced, such in terms of vocal, gestural, and verbal signals. While on the other hand, the receptive ability of the person refers to the process of receiving and comprehending language messages, meaning how they were able to understand what other people are telling them, which would likely tell us that language skills need to be assessed in both expressive and receptive modalities, as these may differ in severity. Like, for example, an individual's expressive language may be severely impaired, meaning that person could not easily find the words to say and find it difficult in his vocabulary bank how to express, describe, and use words to express himself, while his receptive language is hardly impaired at all, meaning he could understand what is being communicated by another individual and gets the message as how it was delivered and communicated to him or her. Now, the onset of language disorder is likely at age 4 years and up, because at 3 years old, a child is expected to have learned how to communicate, to use language, symbols, and verbal signals to express himself or herself. And at the age of 4 years old, if this is not likely successfully achieved as a milestone for the child, then it might lead us to the understanding that deficits in language might be present. Now, before with DSM-4-DR, the below standardized measures both nonverbal intellectual capacity and receptive language development. They are likely to check the vocabulary, the tense, and the sentences made by the individual. And also, individuals have difficulties with expressive language. It may also interfere with academic and occupational or social communication. So the person's inability to use language, may it be verbal or non-verbal signals, could likely tell us that these are the red flags to consider that a client or a patient might be suffering from a language disorder. So to establish a language disorder diagnosis, the diagnosis must be based on the synthesis of the individual's history, clinical observations in different contexts, and scores from standardized tests of language ability. And still, a standardized test result from a language ability test is necessary for us to determine and validate that the person is likely to have a language disorder. And second, language disorders emerge during the early developmental period. By age 4, individual differences in language ability are more stable and typically they persist into adulthood. So likely if the person has difficulty in using the language at age 4, then it may persist up until adulthood. When the child meets criteria for an intellectual disability, separate diagnosis of the language disorder is not a given unless the language deficits are clearly in excess of the intellectual limitations. Now, this statement is likely observing one of the three common criteria for the diagnosis of a mental disorder, which is a mental disorder must not be better explained by another mental condition. So in this case, we would understand that a diagnosis for the language disorder should only be ruled in if there is that excess of symptoms rather than having intellectual disorder symptoms. So let's move now to the speech sound disorder, which is the second communication or second mental disorder under the communication disorders. In the DSM-4 TR, back then it was known as phonological disorder, which tells us through the label, obviously, that the problem mainly is about phonology and articulation. Phonology, which is about the production of sounds as the person would be uttering words. And basically, articulation would go hand in hand with phonology, which basically pertains to how the person was able to successfully utter a certain word or words, which in this case would give us an idea that the person is likely having difficulty with phonological knowledge of speech sound or the ability to coordinate movements for speech in varying degrees. And speech sound disorder is diagnosed when speech sound production is not what would be expected based on the child's age and developmental stage. It is not also likely to be the result of physical, structural, neurological, or hearing impairment, meaning these circumstances are not attributable to the speech sound disorder. And language disorder may co-occur with speech sound disorder because the mastery of speech sound production should result in mostly intelligible speech at age 3. And to further deepen our understanding of speech sound disorder, we also have the late 8 letters, which are the following: L, R, S, Z, TH, CH, DZH, and ZH, which would likely entail that people who are having problems with articulation and phonology, basically about speech sound, these individuals are likely to have difficulties in uttering these late 8 letters. Sometimes when people are asked to utter the word gas, some people might say das. And they are not intentionally doing that. Basically, they are having a difficulty in uttering these words. That's why they are suffering from speech sound disorder. Now, moving forward with childhood onset fluency disorder, which is the third on the list for communication disorders. Childhood onset fluency disorder, or labeled or categorized as stuttering, are disturbances in the normal fluency and time patterning of speech, as well as anxiety about speaking or limitations in effective communication and socialization. Childhood fluency disorder occurs by age 6 for 80% of the affected individuals, and the severity of fluency at age 8 predicts recovery or persistence into adolescence and beyond. Meaning, at the age of 8 years old, likely, we could know that the person may be in recovery or the problem still persists. Now, the problem focuses more on sound prolongation, meaning in uttering some words, in trying to also come up with a sentence, the person is likely prolonging the words or the utterance of some words. And another is also broken words, audible or sound blocking, and a monosyllabic whole word repetition. Now, talking about broken words, likely when the person is talking, he or she takes some pauses within a word. And to understand audible or silent blocking, there are fillers used by the person, like the ums, the ums, or unfilled pauses in speech. An occurrence of circumlocutions, or meaning the person would be looking for substitute for the words that are seen to be problematic. So instead of using the term affluent, the person would choose to use the word wealthy, or there is a clear avoidance of the utilization of a particular word because the person is not familiar, or likely there is anxiety in utilizing such term, wherein the person may have a difficulty in uttering or in expressing or articulating such word. And there is also that monosyllabic whole word repetition. So, like for example, when the person would be saying, instead of saying "I see him" clearly, the person would be saying I, 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 I see him. So it's not just a word, but it's like a monosyllabic whole word repetition. So it's a word in a sentence utilized by the individual, and likely the words are being repeated in order to get across the sentence or the message that he or she wants to also deliver to another individual. Now, moving forward to social communication disorder. This disorder is a new disorder under the DSM-5, and it is designed to capture children who have severe deficits in social communication and interaction, but who lack the restrictive and repetitive behavior patterns, which are necessary symptoms for the diagnosis of autism spectrum disorder, or ASD. And these children have typically been diagnosed with pervasive developmental disorder, not other specified. Now, this problem is typified by the persistent difficulties in social use of verbal and non-verbal communication, as manifested by, like, meaning to say there is difficulty following rules for social nuances in communication, such as social rules for discourse or inability to follow non-verbal cues. So for social communication disorder, primarily, it's the difficulty with pragmatics. That's why it's labeled pragmatic. Pragmatics is the social use of language and communication as manifested by deficits in understanding and following social rules of verbal and nonverbal communication in naturalistic contexts. So how does that manifest? So, like for example, when a certain child will be talking to another child, in the normal rules of communication and exchange, or even conversations, there is likely that exchange of stories. So the one being the listener first, and then simultaneously he would also become the sharer. But on this particular problem, the patient is likely having difficulty in trying to exchange with conversations with another child because he or she has the tendency to always share about a story, and he or she is the one doing the conversation. And likely, even if the other child shows disinterest, or the child is no longer interested to listen, still the child would continue to share his or her story. And there is also um, the difficulty in changing language according to the needs of the listener or situation. So, if by chance in normal conversations we could observe that our listener is not interested with a particular topic that we are talking about, we are likely to change the language and to shift to another topic. But the problem with the individual having social communication disorder is that they don't really have that sensitivity to also change the course of the conversation. And the deficits in social communication results in functional limitations in effective communication, social participation, development of social relationships, academic achievement, or occupational performance. And the deficits are not better explained by low abilities in the domains of structural language or cognitive ability. Now, differential diagnosis would be ASD in case there is the presence of restricted repetitive patterns of behavior, or RRBs, and likely when it comes to interests or activities. Just to summarize, the social pragmatic communication disorder, when an individual would be having such condition, likely there is that deficit in social purpose. So just like, for example, greeting and sharing information, there is likely a barrier with regard to the ability of the individual to greet and also share information. And there is also the context might be a problem with the individual having the condition, meaning there could be possibilities wherein the person is likely insistently talking about academic performance, even if they are playing in the playground. Okay, when it comes to kids, this individual is likely communicating about a certain context that is not related to the current setting or the context of a certain conversation. And the person is likely having some challenges in following conversation rules, meaning that individual is incapable of taking turns when it comes to exchanging messages. So there is repetition, persistence, and all you have to do is to look into the DSM-5, because we need to have at least 6 symptoms of the said disorder for the diagnosis. With regard to the history of social pragmatic communication disorder, there is that associated feature from the language impairment, which you could also be seeing problems in relation to repetitions of words. There is also persistence, and in 8 different patterns of speech, like sound and syllable repetition, sound prolongations, interjections, the broken words, the audible or silent blocking, circumlocutions, words produced with excess of physical tension, and the monosyllabic whole word repetitions. Basically, these are some of the symptoms found, or conditions found from the DSM-4 TR back then. And the person is likely to also be non-literal, meaning they are having difficulties in understanding what is not explicitly stated, and non-literal or ambiguous meanings of language, like they don't understand idioms, humor, metaphors, or multiple meanings that depend on the context for interpretation. And likely the problem uh, would start at the age of 4 or 5 years old.